Hello, oral surgery colleagues, and welcome to the Oral Surgery Podcast. I am your host, Dr Richard Moore, an oral surgeon based in the United Kingdom. The aim of this podcast channel is to discuss ways of improving practice in oral surgery, thereby creating a better journey and patient experience, and allowing us as clinicians to become better oral surgeons. All discussions on this channel are based on personal experience and opinions, which should be thought-provoking and supplemented with further research and evidence-based practice. Without further ado, let's jump into this podcast. Hi, and welcome to this Oral Surgery Podcast. Today I have with me Rhian Jones, who's an oral surgeon in South Wales. So hi, Rhian.
Hello.
Thanks for joining me. You are not unusual, but I guess unique in the fact that you are a primary care oral surgeon and exclusively working in primary care.
Yes, I am, and have been since exclusively primary care since 2012.
Okay, so you're. We'll just go back to, well, not many moons ago, but you did a slightly, well, not different route, but the training program in oral surgery was slightly different then because it was the M-Surg Dent, whereas now it's the M-Oral Surg. So you did a slightly different path, well, slightly different program, I guess, than the current trainees.
Yeah, I think Harriet and I were probably the third and fourth SPRs in the UK. So the first two were in Scotland somewhere, and when we started, it was an M-Surg Dent. So you were going to be a surgical dentist, which as there was no oral surgery at the time. So I think I'm one of the few people to have an M-Surg Dent after my name, which does fox some people.
Yeah, you do see a few bouncing around, but that's quite unique. So I guess once you'd finished that, which you trained in Birmingham, which is where we met, and then...
Yes, when you were a mere child and I was a slip of a girl. Yeah, it was quite a while ago.
Oh, it's not that far. We'll just cover over that. But did you then go straight into primary care after you finished training?
I'd only worked 1 year in practice before going into hospital jobs. I actually did a house officer post first in Cardiff and then VT, and that VT year is my only general practice year. I knew it was going to be oral surgery, and I knew that's what I wanted to do. So after coming up to Birmingham and working in a couple of SHO posts, I had it in my mind that I wanted to do oral surgery in primary care, but at the time there weren't many places. So in fact, very few that were doing it exclusively. So I relocated back down to South Wales, which is where I'm from originally, where my family is. And initially, I worked as a staff grade in the Max Fax unit at Morriston. That was full-time while I found a premises and opened a squat, which people thought I was mad, I have to say. But I did it. I just opened a squat and sent letters out to GDPs saying, I'm opening and I'm here to do oral surgery. Anything that you're not comfortable doing can be referred. And at the time, it was fee per item. So I didn't have a contract, but I also didn't have any restrictions on how many patients I could see or what I could see.
Okay.
So I just opened the door and it was a bit like Field of Dreams, build it and they will come. But thankfully they did. So
yeah, and looking at, I just had a quick peek at your website before we came online, and I didn't realise that you had such a big team. I thought it was, I wouldn't say a one-man band, but I didn't realise that you had, more than you doing oral surgery, and it, it looks a fairly successful practice. But did you then just go from complete full-time hospital work or did you do a bit of a transition period with, opening the practice? And were you the only dentist in the practice then?
Yeah. So initially I was the only dentist, and I was there. I think I dropped the staff grade job down to 2.5 days a week. So I was half time in each post. And when I wasn't at the practice, I had a nurse that worked full time. So at the beginning, don't laugh about this now, but I had my mum as my receptionist, and I employed a full time nurse. So when I wasn't at the practice, she was there answering the phones and dealing with anybody, any post ops. Then were booked in, and I'd come and see them at the end of the day. It was very much building it from the grassroots up. And I was on my own. I opened in 2004. 2005, February 2005, and I was on my own up until 2007 when I was pregnant with my eldest, our eldest daughter, and I knew then that obviously I had to go off for some part of that. So I got a couple of my colleagues that were at the time staff grades in Morriston, and also one that was an SBI. He was just starting his consultancy actually. So they came and they were working 1 day a week each for me. So it was, and that was an easy transition. And both of those guys are still with me now. I've relocated the practice, and yes, we are a much bigger team. We are currently 7 oral surgeons, all working part time. Most of them work a day a week or a day a fortnight. But 2 of them are the original 2 that started with me back in 2007.
I mean, there can't be, and I'm sure somebody will correct me and tell me I'm wrong here, but there can't be many practices in the UK with 7 oral surgeons, albeit part time in and out. I think that's quite unique.
I think so. I think I mean, one of the things I realized was I started doing implants around about 2008, and I didn't want to do the restorative side. Having only done 1 year of VT and not touched it since, I felt that would be slightly unethical and irresponsible to decide I'm suddenly going to start restoring implants. So, one of my friends who had been in school with me, and then we'd gone to dental school together. He was working in Banstead at the time, but back and forth to Merthyr. So he was in the area every now and again. So I said, did he want to come and do initially 1 day a month restoring implants? And he now is my business partner. So it's amazing how you start something small and you decide you're going to go down a path, and then suddenly it snowballs into something else. And part of the reason for doing the implants was really to have a separate income stream,
Yeah.
because with the oral surgery side, and in 2006 the new contract came in, and um, that really did shake the business a little bit, because I went from having free reign and being able to see however many patients came to the door, albeit fee per item, which is not, was really poorly paid. Suddenly the local health board had to give me a contract because I had some historic evidence of work, but it was a very small contract. It was only £35,000. So I quickly realised, well, you can't rely on that then. You can't rely on the NHS being able to provide any more than that, or being able to negotiate or argue the point that I was worth more than that. So I needed a different income stream. So the implant side of it was to that end. And actually, it's a really nice thing to do because, well, as you know, oral surgery, people don't particularly like coming in to see us for the most part, and you're taking teeth out. And as much as people are grateful, it's not something they really look forward to. Whereas at least with all the implant work we do, it's very much elective. People want to have it done. They are happy with it. It's giving them something back. You see an end result, that's great. So there are lots of plus points to the implant side of stuff that I
Yeah.
do as well, which makes my work a nice balance.
And it kind of goes hand in hand with kind of exodontia, doesn't it? If you're going to extract, then it seems sensible for you to restore the surgical aspect. And I totally agree with you with the restorative. I did a little bit, and it's just it's uncomfortable. And I think really for
Yeah.
the best result, you do need somebody that is on point with that. I,
Yeah.
I mean. Hats off to you to kind of think, I'm just going to set up from scratch. You didn't even buy a practice that was up and running with a general contract. It was just like
No.
did you have to convert it as well?
Yeah, honestly, I think I was a bit mad. I probably am still a bit mad, but I just had this deep-seated belief that oral surgery, for the most part, did not need to be done in secondary care. There are some cases that undoubtedly do,
Yeah,
and there are some cases that you need the resources of the hospital and GA and inpatient facilities, the expertise that are there, or you need it for training those people coming through.
yeah,
But for most of it, the patients don't need to be in that environment. They just need the right pair of hands. The kit that you use is not special to a hospital. Um, and what I got frustrated of with the hospitals, with every department I've worked in, and this is no fault of the departments, it's just the way the hospitals are set up. They see SHO or staff grade list, is it, or whatever it's called, a DCT2 list, and it's right. You're going to have 3 patients booked in. It didn't matter that I could very comfortably see 3 patients and then be sitting around for an hour and a half having coffee, or doing notes or whatever else I was doing. It didn't matter that I would say, well, we can book in this patient there. No, you've got your 3 patients. That's all you're having in that session. It seems such a waste of clinical time. If a patient cancelled, there was not the ability to then backfill that appointment, so appointment times were being wasted, for lots of different reasons. But it's very hard to get patients to come into a hospital if you haven't got a list of cancellation list, or the admin staff, or the process in place to fill that appointment at short notice.
Yeah.
And things like that just frustrated me, and I could see that it was a resource that was not being used to its best ability, and I felt I could do a more efficient job in primary care.
Yeah.
So that's what I did.
And I think I totally agree with you with, oral surgery being carried out in primary care. The majority of it can be by the right person, in the right environment with the right support and the right training. And I think that kind of brings me on quite nicely to the trainees that certainly we've got now. There are very few secondary care jobs, certainly very few consultant oral surgery jobs. And I'm not going to
Yeah.
get political, and I know there's lots of drive to try and change that. But that's not going to change overnight. And we've got trainees. Training numbers are increasing, so trainees are coming out. We've had a couple recently out of Yorkshire that there isn't consultant jobs for them, so they've gone back to either a staff grade or a specialty dentist job, which is what they were doing before. Although admittedly now they're a specialist. What's changed for them, and actually should we be looking at introducing some element of training in primary care within the STR rotations to then say, well, actually, because I do a little bit of primary care work, and I did some level 2 work before, and it's so different. You think in the hospital, if anything happens here, I've got support of people around, but actually in primary care, you're so not isolated, but it's a completely different ball game, isn't it? And I think that's obviously a challenge that we don't train our STRs for. And like you've said, most of them have probably done 1 year foundation training now, and then come straight into DCT1, DCT2, and all of that's in the hospital environment. So, it would be nice to hear, I guess, the challenges. Although you said that one of the reasons you went into primary care was to because you could offer so much more for patients and be more efficient, but that comes with different challenges.
Yeah, it does. I mean, there are lots of aspects to being in primary care, especially if you run the practice yourself. Now, that was always part of the attraction for me. I wanted to have a business, and to have that management side as well, because I've always been very financially minded, and not to say that I want to earn a big wage. Yeah, I do all right, don't get me wrong, but it wasn't that. It's actually just I do like the process of running the business, and I don't think anybody that's doing an SPR post now has any exposure to that. And it's funny that you were saying about the training thing. We've been speaking, I'm chair of the South West Wales Oral Surgery MCN, and I'm the vice chair of the Oral Surgery Specialist Advisory Forum for Wales. And we are trying to do lots of things to increase the number of oral surgeons, NTN numbers, but also a DES status. And part of this is that I've been speaking to local max fax units about whether we could incorporate a training pathway where they spend some time in primary care for lots of reasons. In that, it's really good hands-on. You'll see an awful lot of patients. They'll get the expertise of the oral surgeons who's working in the practice to help them out, and if they get a bit stuck or they want to discuss cases, or to supervise in the early part of their training, and but also they'll get to see the background of running a practice and have an idea of that environment and the different things you've got to manage, HR stuff, managing staff, managing, knowing about your sick leave, and the COVID sick leave is just ridiculous. There's all sorts of things like that you have to learn on the hoof a little bit, and I don't think you get any exposure to that as an SPR in a hospital setting, because you don't know any of that's going on in the background.
Yeah, and I guess you learnt that on the job, did you? Didn't go away and do an MBA, on a Wednesday afternoon.
No, I didn't. I mean, I am no, I'm very lucky. My mum has always had her own business, and so I've always had a really strong role model in that respect. And I'm very clever in that I married a wonderful man who has a HR in. He's got an he's got an MSc in human resources HR, and he also has done an MBA. So he is very handy to have around, and he does work for me now 1 day a week as well, sort of overseeing all the policies and all the things that I really haven't got time to do. We've had a fire inspection recently, and that's thrown up some things we've got to change, and there's all sorts of stuff like that that I get Gareth to do for us, and he's far better at it than I am as well. So it's about choosing your team well.
Or husband, yeah, definitely.
Or
I mean
husband, yeah.
that's. I mean, yeah. I mean, to try and incorporate that into clinical training is almost impossible, isn't it? And I think dentistry is
Yeah.
unique in that respect. But it's interesting that other dental specialties that are very primary care based, like orthodontics, I guess restorative, not to a lesser extent, maybe, but maybe orthodontists are just born with that financial drive, or they just work in practices where the practice is already set up, rather than. I
Yeah.
think what you did was pretty. I'm going to say brave, but admirable,
Yeah.
because you've pulled it
Yeah.
off and it's worked well. And actually, the things that you're now doing and trying to get in training integrated is exactly what it needs. Now, I don't know anywhere else in the UK that's doing that, but I think it's really important.
Yeah, I think it. I mean, we don't teach at undergrad level, do we? We expect we train dentists, and for the most part, a general dentist will work in a primary care environment, and they're self-employed, and we don't give them any advice or background on how to do that. How to do a profit and loss sheet, or what um, a tax return is, or how you. We don't give anything like that,
No.
and we're expecting these people to go and work. They can do the clinical side. Uh, but they can't. How can they manage the rest of it? And you have to learn that on the job. And if you make errors, it can be very costly. So I think that's a failing. But the trouble is, it'll come down to how much time you have at undergraduate level, and what do you sacrifice
Yeah.
in order to get this bit in. And I suppose the same for the specialist training as well. At least if we can move some of it into primary care, there will be an exposure to it. And I'm sure it'll be part of the conversation then while they're in that environment. So that would be the hope anyway,
Yeah.
so that they could see a different side of it.
Uh,
I think it is frustrating for people coming out of training, and where do they go next?
yeah.
What's their next role? Because there aren't associate specialist posts any longer, or they're very few or far between. So then they go back to being a staff grade. And yes, when you were doing a staff grade role before, or specialty doctor role before you went into training, to go back to that then, albeit on the specialist list, must feel a bit
Yeah.
frustrating.
And your job description and day to day may be no different. And
No,
then people will question, say, what's the point in doing 3 years training, or even 4 years when it changes to come back to what I was doing before? So yeah,
yeah,
it's really difficult. And just touching on the primary care training with registrars, especially with my interest with my PhD, is getting undergraduates into a practice like yours that they could see some oral surgery, because you're limited in the hospital, especially with COVID. Now we've got restrictions on footfall through the waiting rooms. Whereas, and I
mm,
appreciate in primary care you've still got restrictions, but actually for them to come and spend a week, a day with you, a month, maybe for 3 or 4 months, they would get so much more out of that than seeing one patient in a session at the hospital.
mm.
So yeah,
Yeah, I
there's,
mean, I suppose that's the issue with a big building, isn't it? That you've got all these clinics, but the pinch points mean that you're restricted in your numbers. It's not that
yeah,
you can't get them onto the clinics; you just can't get them through the building and into the clinic seat.
yeah.
With us, we do have a restriction still, but we manage it by keeping people in their cars until just before they're allowed to come
Well,
in.
yeah,
So,
and that's the other reason
and
people like primary care. They can park,
yeah,
and it's sometimes free.
yeah, yeah,
Whereas certainly
yeah,
where I
yeah.
work,
It is.
it's not, and it's
Yeah,
it's
it's
impossible to
not.
park. Um,
That's hard, isn't it?
yeah. So
I mean, it's interesting. Sorry about the undergrad thing. We did have DCT 1 and 2 in the practice for a little while. It was sort of a pilot scheme in the area, and they did a week in Port Talbot Resource Centre doing general dentistry, and then a week in various different clinics doing oral surgery max fac. So I would had this group of young dentists that would come to me one day a fortnight for a year. Um, and they were, the first rotation in particular, were very, very good. And it didn't work quite so well the second rotation, but I think there were more issues in terms of um, embedding the learning with some of them, and they had gaps. They were off, or then I was off, and all you have to do is miss a fortnight, and suddenly it feels like you haven't seen
yeah,
them. Well, you
yeah,
haven't seen them for a month, and so there were things that we could have tweaked with that to get it more efficient. But unfortunately, we weren't given the chance. The scheme was withdrawn, but yeah, I think that was a good opportunity and something else that could be looked at. It's just
yeah,
it's thinking
definitely.
slightly outside the box with these things.
Yeah. So I guess your working week is a mixture of contracted NHS oral surgery, is it, plus some
Yeah,
private work? And
yeah.
I mean, everybody always, well, there isn't a lot of private oral surgery work. Is that? Do you find? I don't know what South Wales is like, but
Well, it's we were actually drowning in referrals. In
oh,
all honesty, yeah. So it's not. Uh,
is that
it
because
sounds
waiting
dreadful,
lists are
but
high, or
yeah,
ah, okay,
yeah. I
okay,
mean, that's the
yeah,
problem. Is that I think we've got an NHS PDS contract, and pre-COVID, the waiting list for that was creeping up to about 11 months,
oh wow,
and it currently is now about 18 months. But we've changed the way we work that contract slightly in that we, especially on the back of COVID, and I think it's probably a good thing in that if people are having problems, so they're in pain, and they ring or the dentist rings us to tell us this patient isn't managing with antibiotics or painkillers or whatever's appropriate, um, then we will get them in within the next couple of weeks. So they essentially they don't sit on the waiting list.
okay,
Um, and then the people that are sitting on the waiting list are asymptomatic and therefore relatively happy to wait
yeah,
because they're not having issues or problems. So you're relying on the patient or the dentist letting us know if something needs to be escalated. So there is a variance in that waiting list. And it's the same. We've got another contract with Howell Thar, which is a service level agreement, and the service level agreement is easier to manage in terms of paperwork and appointment structure, but it's not superannuated.
right, okay,
So that's a little bit of a shame because I think it's just a shame. The SBU contract, I can see the PDS thing finishing because of the whole UDA system potentially. There's been
yeah,
grumblings afoot about that
yeah,
stopping, and so on the back of those two, as much as we try to manage patients as quickly as we can, especially if they're having problems, there are always some patients who like the convenience of choosing their appointment time or day,
mm,
or like like being able to say, well, actually, I'd like to be seen as soon as possible, and I'm happy to pay for it.
yeah,
So we do have a steady influx of private referrals at the moment. So
okay.
yeah, we are busy. Um,
So I'm going to ask you some top tips. What for STRs or even dentists with like a special interest in oral surgery. Top tips about implant training. What would you recommend? Even though it's part of the oral surgery curriculum, but for
yeah.
dentists that are perhaps staff grades that wanting to get into a contract and do a little bit of implant work, what kind of tips would you give them or advice?
Um, I think now with the way things are currently, I don't think just having enough clinical experience is sufficient or shouldn't be sufficient. I think you do need some sort of qualification to back it up. If I was starting again now, I'd probably would look at doing at least a diploma or a certificate in implantology. So finding a good centre and doing that there to get the theoretical background behind it as well as some hands-on training. I mean, I did some as part of my SPR training, and I did some courses with Straumann, but I didn't get a qualification in it. And I think now I'm 15 years down the line. Um, so I don't feel it's something I want to do now because I've
Yeah,
obviously have built my skills up. But if I was starting afresh, then that I think
yeah.
that's something you really do have to do now.
But also diplomas didn't really. I mean, I'm the same as you. They didn't really exist then, did they? In implants, it was.
No.
But now every man and his dog's placing implants. You need to be totally au fait with pros and cons and planning and procedures really.
Yeah,
Um,
you do, and you need to be able to plan it properly, and you need to be able to show evidence to the patient that
yeah,
you've got the experience to do it. I think so.
yeah,
Yeah, you're right. They weren't around. I mean, there was nothing. There was just the weekend
yeah,
courses when I
yeah.
started. So
2 days
yeah,
in Gatwick is.
yeah, yeah, yeah.
Um, and then I guess also just what advice would you give somebody coming out of training wanting to get into primary care oral surgery? Because you flick through the BDJ or NHS jobs; those jobs aren't really advertised, are they? That it's
They're not. It's all a bit word of mouth. And I was actually thinking about this before we came on. And in an ideal world, there's part of me that thinks there would be nice to have some sort of national register of all practices that do oral
Hmm,
surgery, and somewhere that um, and on that site then you could advertise for people to become available because it's all word of mouth. Everybody that I've got working for me, it started off with the 2 that I knew, and then as we got busier and I needed somebody else, so I was taking on more implant work, so I wanted to drop a bit more of the oral surgery. I asked the guys I knew, they recommended people, and then they come for an interview, we start them off. Yeah, they the feedback from the team, the nurses that are working with them is good, so then they come on board. And I've recently taken on two new oral surgeons, and they've both been taken on within the last 4 months, and they're doing really well. They're brilliant. They both work 1 day a fortnight, and but it's all through word of mouth.
Yeah.
I haven't had to advertise, but on the other hand, if there was a register or something like that available, I mean, if you put it in the BGJ, you never quite know
what you're going to get
when you're going to get. And you do want that personal recommendation. You need that. And
yeah.
I mean, there have been times in the past when I've tried to coerce people to come down and relocate to South Wales.
Well, I was just going to say,
Nobody's taken me up on the offer.
Who would have thought there would even be 7 oral surgeons in South Wales to work in one practice? It's so yeah, I guess it's interesting, but it is tough for those guys, and I guess there isn't such a register, but that brings me very nicely on to BAOS. And for those people listening, that's the British Association of Oral Surgeons, and Rhian is president-elect. So you'll start your term.
A year September,
okay.
I think.
So currently it's
a little while.
Julie Burke's current president, isn't she?
Yes.
And we're going to do, well, not a plug for BAOS, but for those oral surgeons or people who are interested in oral surgery, I sat on council a couple of years ago, and it's definitely worth joining. There's a face-to-face conference. I'm correct in saying that, aren't I? Later this year.
Yeah, in November. Yeah, so we did postpone it. It was supposed to be. Oh well, we've postponed it all through COVID, and then initially we did sort of preliminary book it for March, and we just had a feeling that things were going to escalate again, so we've pushed it back to November. I can only hope that by then we'll have got used to whatever variants are occurring, and we'll be more sort of managing them. I'm hopeful that a bit more like the flu, that we are all able to just get on with things. So it's a 2-day conference this year. We've reduced it from 3 days to 2 days. So
okay. Any teasers of who might be speaking or topics, or is that top secret?
Oh, top secret.
Oh, okay.
Yeah. No, that's because I can't really remember.
I should have primed you before we came on. But it's in Edinburgh.
It'll be awesome. Yes, it's
So yeah,
it's a good mix of speakers, and a little bit on steroid cover if we can, because of the whole change in steroid guidance.
Hot topic,
Yeah. Back to life, back to reality is the name of it.
And
Julie showing her age with that, I think.
And for those listening that are not oral surgeons, there's plenty of material for dentists with a special interest, DCTs, post competitions, all that, and there's also usually a nurses session. Is that still?
Yes, definitely still a nurses session, but it's not. I mean, in no way is it aimed just at specialist oral surgeons. And I mean, I should say some of the guys that work for me are not on the specialist list. They're staff grades with over 5 years experience, and really, if they'd had training posts available, would have been on training posts. But we both know how difficult it is to get onto a training post. So, but they all come to the conference. It's for anybody that works in a Max Fax or has any sort of oral surgery interest at all. Then I think you will find something in the conference that is of use to you. And the networking is really good. You get to meet people.
Everybody's very friendly, and the social events, alcohol or no alcohol, are usually pretty fun. So
yes, united by a love of gin. I think we were, Richard, weren't we?
That's top secret. Yeah. So great. It's been great talking to you. I hope this is interesting for people, particularly in the UK, coming out of training and thinking about primary care. And who knows where we might be in sort of 5 years' time with training posts and primary care contracts. So really interested to chat. And thanks very much for joining me, Rhian.
No, you're welcome. Thanks for having me on.